Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have a returning guest, Dr. Emma Westermann. Welcome back.
Thank you so much, Carrie.
Yes, it's awesome having you on again. Just to remind everybody, why don't you tell us briefly a little bit about who you are and what you do? And obviously, that's going to be a focus on what we're talking about today. So, just like a short thing is fine.
Perhaps I should address you as Dr. Reller. Sorry.
That's okay.
Okay, so I was hoping that we could talk about my path from doing a health policy training program at Harvard and how that informed kind of how I perceive the healthcare system and eventually led me to doing direct care. And now I'm opening a coaching business.
Yeah, you're wearing many hats and doing amazing things. So I can't wait to hear about basically your past and where this is going to for your future too. So, like you said you did, is it a Harvard health policy degree? Is that correct?
Yes.
Okay.
So after my third year of medical school, I went up to Boston and studied health policy. And I was kind of surprised at how, you know, being a doctor in training, the atmosphere was not very pro physician. I got that sense pretty early on. The leader of the training program was on the board of one of the biggest insurance companies in the country. So I'm kind of taking notes as I'm going along and trying to understand the different forces that are at play, shaping American health policy, taking all these courses.
So, what does that mean? What is health policy? Just for people who maybe don't pay attention to any of that stuff.
There's many different sectors of health policy. So when you join the program, you have to choose a track within it, and that's a whole nother story. But health policy in general is how do legislators come to decide on the laws and regulations that are going to shape, healthcare in this country. And that occurs at the local level, the state level, the federal level. It's a very complex beast, as you know.
Yeah.
I originally went to be in the ethics track because I was interested in just, the ethics of healthcare. And for a variety of reasons, that track kind of fell apart in my first year or two there. One of the leaders became a dean and so forth. So,
Mm.
and meanwhile, I was taking courses in statistics and really enjoying them. So I ended up switching to a different track that was more mathy and learning a lot of, statistics and modeling. And I did take some ethics courses as well and philosophy courses, which were the best part of the program, but focused on the statistics part.
So, with health policy, like where does that, I guess, where did that lead you? And you're saying I cut you off, but I wanted to explain what health policy is. So, you said the person in charge was who again?
So I don't know that I want to call them out by name,
No, no, no. I don't want a
but
name. I meant what is their type of profession? Is it a pharmaceutical company or is it, like what kind of how does that mean? Or
okay,
private equity?
so the program was led by a Harvard professor who also happens to be on the board of one of the big insurance companies.
Got it. Insurance
And
company.
so you mentioned pharma. So
Hmm.
that was a really interesting part of the training was finding out that physicians at the time, and this was goodness, like 15 years ago or more now, but I don't think it would have changed very much. But physicians and all of the money that patients pay to physicians to do what we do, that makes up only about 8% of the healthcare expenditure pie. We get
Hmm.
blamed a lot for being, greedy and why does it cost so much? And why is my doctor charging me $4,000 and so forth? But we actually don't, we're actually not the problem. And then the next sector that often gets a lot of blame from the public is big pharma. It's a lot of hatred towards them. And I get it. I mean, there are problems, but we did a whole analysis of, how much does it cost to do the research that big pharma does to be able to offer these very innovative therapies that often are available, first in the US and nowhere else in the world. How much does it cost them? And how much does it cost to make those therapies available in different parts of the world, like Europe and even less developed nations that can't afford the price tag that we pay? And Americans are actually offsetting those costs. For example, they can't charge as much in Europe for many of the medications that we develop here.
Mhm.
So they have to charge more here
Mhm.
because our health policy is different from that in Europe. Anyhow, not to go into too many nitty-gritty details. The bottom line is that yes, there are issues with big pharma, but they are, again, not the major problem in terms of healthcare expenditure. The major problem is insurance companies and their overhead and the many, many layers of bureaucracy inherent in those mega businesses. That's where most of the money is getting spent and often wasted.
Yeah, I mean, I definitely agree. I think that you mentioned like deprofessionalization of medicine, right? How would you like talk about that and describe that from your experience at Harvard?
Yeah, so we were talking about that earlier. So when I was in college, I took a history of medicine class and we read The Professionalization of American Medicine or something like that. It's a really thick book, a wonderful book by Paul Starr, I believe. And it talks about how physicians went from just being barbers almost on the fringe of society to being highly respected, very well paid in this country. And now I think we're witnessing the deprofessionalization of medicine. So where the public no longer really respects us. There's not a clear difference in most of the public's eye between physicians and ARNPs and chiropractors and all different kinds of providers, naturopaths, they're all called doctor. And the years and years and years that we put into our training, public really doesn't understand how that's different from some of these other providers. Not to, say that some of them aren't excellent. Some of them are. And I've had patients that have benefited from seeing some of those types of providers, but respect for physicians has really eroded. We see that and feel that every day in, you know, patients who are angry at us for the cost of their care, patients who are angry at wait times, not being able to get in to see us, and angry that we can only spend 10 minutes with them. The thing that's driving all of that, again, is the insurance industry, which forces us to see more and more patients every day because the reimbursements every year are going down and often controls what we can do. I mean, even as a direct care physician, which we'll talk about what that is later, I don't take insurance for my consult fee, but I bill IVIG and medications through insurance. So I have to fight with insurance companies, and that takes a ridiculous amount of time that patients don't see.
Mhm, mhm. Some of the, you mentioned like 8.8% goes to physicians. What is all the rest of it?
So I don't remember the percentages, but there's a decent chunk. Like I would estimate, say 20-25% goes to the pharmaceutical industry, perhaps.
Mhm.
But the biggest chunk goes to the insurance industry and the administrative costs and
Yeah.
overhead.
Yeah. I mean, we've seen a lot of crazy stuff with insurances this year, and including, cyber attacks on United Healthcare, the other unfortunate incident with United Healthcare leader. And, it's scary. And I think, a lot of patients sometimes do feel that burden of, they're not really being treated well, even though they have this insurance, the things are denied, their medications are changed, they can't get the service, the procedures and the surgeries that they need to have done. And I think it's kind of being, I guess, shed light upon these things, right? Even in the public eye, but I don't really know where we're going to go to fix it. That's for sure. So a lot of doctors like yourself are, exiting from the insurance-based world and creating these direct care models, whether specialty or primary. And I don't know if that's the 100% way that we're going to be going in the future, but I think that the things that you're pointing out and the things that you learned, in like you learned, like it sounds like the statistical financial side of it, which is very interesting. That's something I don't know that much about, but I mean, clearly I feel it, right? So I think it's good to be enlightening patients of what's going on there. And I think it's important. Is there anything else that your experience at Harvard like shed light on or made you realize where you're going to end up, I guess, next in your career?
I mean, so many things, but perhaps the most applicable to this conversation is in those computer models that I used to build. We called them at the time cost effectiveness models. So we would be looking at, is this therapy better than that therapy? Not just in efficacy, but putting it into a giant model of the disease state and saying, you know, over the whole course of the patient's life, is this therapy going to be cost effective compared to another? And
Mm-hmm.
to do that, you have to literally value life. You have to assign a value to a year of life. So that would be put into the models, a quality adjusted life year, which at the time was valued at $100,000 and per year of life, right?
Okay.
And that just really never sat well with me. I mean, I understand the necessity and the value and trying to make decision making more objective and that, somebody has to make these tough calls as to what we're going to pay for as a society.
Yeah.
But that wasn't how I wanted to view myself as the arbiter of that kind of decision making. So I've over time moved into direct care where I can have a more personal relationship with my patients. And it's more like a concierge type relationship where I can really invest in them as a person. And I deal primarily with complex disorders that have kind of fallen through the cracks of the healthcare system because nobody under this current incentive system has time to deal with the really complex disorders. And, I try to make it affordable. I am having to reevaluate my pricing structure because I am providing more concierge than direct care due to the complexity of these patients. But yeah, a lot of patients just can't get care anywhere. They've been to 14 different doctors and nobody can find the answer. Or nobody will even give them the time of day. So I end up
Mm-hmm.
seeing them.
Yeah. Going back to what you mentioned about like who's making the call of costs and things like that, I think a pretty good example right now would be with the anti-obesity medications, because someone is determining whether, what is the cost of this person being on this medication long term, and is this preventing them from having to take all the other medications or all the other chronic diseases that they were having. So somebody is having to do that cost analysis, and I guess recently the current administration has decided that, it's not favorable, so they are not covering them. But I don't know, that's still, work to be determined. But I thought it was interesting, kind of applicable to what the whole, like, reference to the policy of what's going on with that. And it's also important with the whole, how you said we pay more for the medicines here than they do in the other countries, because I think these medicines are so popular right now that people are paying attention to these things, and they're realizing, yeah, they're way cheaper in Canada, they're way cheaper in Europe. Why are they so expensive here, and what's the situation? And we're trying to get the cost down for that too. But as most people know, like Medicare and the marketplace things are not covering these medicines. I mean, that's just one example of many, right? And the same thing, I feel the same way when putting people on, the chronic asthma medicines that might cost longer, but keep the patients out of the hospital, maybe, less steroid use, which creates other long-term effects and things like that. So those are all the risk benefits that have to be weighed when they're deciding either what costs something, who's going to cover something. There's a lot that goes into it for sure. And a way to step outside of these things, maybe not as much with medication, but with the, taking the time and the expertise that's needed to care for these types of patients. You're also, saying that they need more comprehensive care too. I mean, you're speaking of different types of patients, but I think that it could be very similar too. So you have now, I guess, created this model of being able to spend time with the patients without the insurance, burden, I guess, right? And it's important, to be
Yeah.
able
And
to do that.
you do a lot of obesity medicine, correct?
Yeah, yeah.
Yeah.
That's why I
And
love
so
that.
I don't do that, but I have heard about that problem where the
Mm-hmm.
GLP-1s, it's
Yeah.
not just that they're not covering them, right? Is it also that they're trying to shut down compounding pharmacies so that you
Um,
can't order smaller volumes of the
Well, that's a little
compounded
bit,
drug?
that's going into a whole nother situation of like patents on the medications, and that would be more on the pharmaceutical side. But I'm just referring to coverage for the medicines, for the brand name drugs. Yeah. If we go
Okay.
into that, we'll never end up talking about anything that you're doing. So let's not go conversation. But how would you say that direct care kind of restores that connection and purpose and patient-centered care that you wish to provide to your patients?
One thing is the amount of time that I can spend
Mhm.
with patients. So my initial consults tend to be 2 hours and follow-ups are 1 hour. So we can cover a lot of ground, not just let's review your labs and I'll do a quick exam and goodbye, but what else is going on in your life? And I see a lot of neuroimmune conditions like PANS and PANDAS, and those
Mhm.
come along with, you know, mental health issues and family strife and sometimes educational difficulties for the child. And child may also be constipated or having urinary accidents just because of this complex disease. So I want to be able to go into all of those things and address them myself or get them to a specialist that deals with that specifically. And that takes time. So I feel like I'm able to provide better care by
Yeah,
devoting that time.
absolutely. Yeah, and you mentioned, the current system isn't able to do that. They kind of leave families on their own and they gotta just figure it out. But you also mentioned, I think we talked more about pandas in the last episode. So you could give us a one-liner what it is so they can remember, but otherwise they can listen to that other episode. But briefly, what is that? Because I think you wanted to tell us, kind of about how you navigated as on the patient side with that condition.
Yeah, so PANDAS is pediatric autoimmune neuropsychiatric syndrome associated with streptococcal infection. And PANS is very similar. It just encompasses, similar symptoms, but attributable to other infections besides strep. So I see patients that have unusual, behavioral issues, neuropsych symptoms, often with rapid onset following an illness. And we evaluate to see if it's PANS or PANDAS. Sometimes it's not, sometimes it's something else. And, a metabolic disorder or other types of complex disorders, which I can also address. And I also look for underlying immune deficiency. So, yes, and I came to this specific disorder because my younger child had PANDAS. I didn't realize it at the time, but he did develop PANDAS when he was about 6. And now he's 11 and doing great.
Yeah, I mean, it's difficult to go through anything when your child is sick, right? But what did you find out during that journey, right, of getting him help, of like what happened with the traditional medical establishment for you there?
So I was really lucky because I'm a physician. So I come to it with that background, with more background than most parents have, and I don't back down. So I kept pushing and kept pushing and kept reading and learning to where I could finally assemble a team around him to
Hmm.
support him and get him healed. But it was very frustrating and it was very lonely at times because everyone was telling me, no, it's not what this is, or the school system was saying, no, he's fine, he's fine. And I could tell that something had changed. His handwriting had gone downhill. He was doing what I now know are very typical, changes in handwriting that are associated with pandas and needed a specific type of occupational therapy, which I was able to get for him. But it was an uphill battle, even for me. And so now that I have fought to get my own child those resources, I feel like I can offer that to other families to get them to the best occupational therapist, the best feeding therapist to deal with, ARFID, which is an eating disorder that often comes with pandas and so forth. I was definitely a lonely battle at times.
Mhm. Yeah, it's very challenging. So I think, having gone through that, like you have now spurred or developed a whole nother, I guess, business model to help patients and families with things like this, correct? Tell me about that.
Yeah, so I am finding that there are cracks in the system for dealing with the mental health care problems that come along with PANS, PANDAS, and other complex disorders. A lot of the patients have PTSD associated with the medical system because they've been told that they're crazy, they've been poked and prodded, they haven't found answers, and they're exhausted. So I'm not a mental health care provider, But through our family's journey, I was exposed to many different types of mental health care that's available. And I've been networking with a lot of mental health care providers locally to kind of see who specializes in each different area. For example, psychodynamic therapy is talk therapy, basically. And then there's
Mhm.
cognitive behavioral therapy, dialectical behavior therapy, internal family systems, which is often called parts work, where you're going back into your past and identifying a part that was traumatized or neglected or what have you, that you're still carrying some sort of wound or trauma associated with that part. And you go back in a sort of meditative way and give that part what it needed, essentially. Sometimes people call it reparenting that part. So I can't lead that therapy, but I can direct patients to books on that therapy and podcasts and therapists who specialize in that. If I can identify that, I think that's what they would benefit from. I read probably 100 books on mental health and neuroimmune conditions and improving communication and all the side effects of having pandas when my son was sick. And through doing that, I can kind of guide patients on the right path. So I'm starting a coaching business to fill those gaps. I have patients that are struggling with addiction and can't get in to see a mental health care provider or can't afford one. And I can offer very short segments of coaching that can hopefully get them on the right path until they can get in to see someone.
Mhm.
And again, not providing mental health care, but just life coaching
Mhm.
it, to get them through that transition period.
Yeah, that's amazing service. Is there any like advice that you would give to families trying to navigate this chronic illness or mental health like struggles other than what you're saying right now? I mean,
So, oh my goodness, I have a reading list that I give to patients. I have a
that's great.
podcast list. I think if we were certainly once I'm in a one-on-one situation with a specific person, I would be able to give targeted advice. I benefited from having not only a therapist, but a life coach through the most difficult period of my child's illness. And it was incredibly expensive. It was upwards of $700 for 4 30-minute sessions in a month, but it was worth it at the time. And I'm not going to be charging anywhere near those kinds of prices as I'm starting out, but the gap in mental health care is so wide that I think we need a lot of people like me to step in and help patients get on the right path.
Mhm. Well, that's a perfect lead into what I was going to say is, one thing we can do is encourage, patients and clients to seek those types of providers like yourself that can focus on that comprehensive care and connection, right? Yeah. And I don't
And
want to,
also, I have
okay.
patients, like just today, I had 2 patients call from out of state that they think their child has pandas. And I can't treat patients out of state because I don't have a multi-state license yet. But I could provide coaching to
Mhm.
say, okay, here's what I would ask your local physicians to think about. Here's what I would consider ordering. Or maybe you might even be a candidate for genetic testing and ask them what they think. And here's what I do with my patients. One was from, a very rural area and had no access to anyone like me, or even just an immunologist. So I'd like to be able to provide that service. And they're welcome to fly down and see me as a patient if they decide they want to do that. But if that's not feasible at this time, maybe through a coaching capacity, I can at least provide some suggestions.
Mhm.
I'm still working out the legal aspects of that, but that would be my hope that I can provide that service.
And help them, navigate the system, obviously, because you've had all that expertise of learning about the broken system with cracks. But let's end on a hopeful note. So you hope you're going to be able to provide this coaching service, which is great. What about with our American healthcare system? Can we say anything that's going positive or in a positive direction?
I am really hopeful. I really am. I'm always an optimist, but I'm really hopeful that direct care
Yeah.
will break the system.
Yeah.
Honestly, I mean, our family pays $25,000 a year for health insurance for a family of four. And that's just in premiums. Then you
Mhm.
have the max out of pocket costs, which are what, 8,000, 10,000, I can't remember, and the deductibles and the copays. And a lot of patients are finding that even with great insurance, they can't see the doctor that they want to see because either they're not in network or that doctor doesn't even take insurance because they've given up on the system. So I think the value of this expensive insurance that we all carry is coming into question, and a lot of patients are experiencing that.
Mhm.
So I think the
Yeah,
more of
I,
us,
honestly, they should question their healthcare plans and really understand it too, because I think that's what some of the disconnect is between their provider and themselves is that they don't understand their insurance and what they signed up for and what it covers and doesn't cover and all of that. And then, the translation between, a provider like me and them is just never, I guess, I don't know, a good thing when they don't quite understand what a copay is, what a deductible is, why we have to collect that. Like the fact that if I don't, I'm never going to keep my doors open. Right. Yeah.
right, exactly.
So,
And they see the bill and they say, well, Dr. Reller billed me $500, what have you, but you didn't, right? We have to charge, and I'm exaggerating. You
of
wouldn't charge
course.
that much, but doctors and facilities have to charge much more than what they're actually going to get paid. Because if we charged what we think we're worth, we would get paid, a third of that, right? So, so you have to charge an exorbitant amount, knowing that you'll only get back a small fraction from the insurance company. Patients don't understand that.
Well, hopefully, like you said, the system will get broken yet fixed, right? And I think we can hope that everything is going to move toward a positive, I guess, outlook. But it is a different time where we have to just figure everything out. And I don't know what the best answer is. And I'm not one to debate anything, but also try to seek a positive outlook. And, I do take insurance and it's hard. Yeah, that's all I want to say about that. I feel like
It's
sometimes it's
very
charity
hard.
work to take the insurance, but
Yeah.
yeah,
Yeah, just
it's a
last week I
difficult
had
thing,
a
and I think it's important for patients to understand that too. But yeah, so if patients do want to work with you, where can they find you?
so I have a website, www.healthspanimmunology.com. They can call 813-869-7111, or they can email healthspanimmunology@gmail.com, and we
Yes.
can set a meet and greet. I think my next openings are in September at this point.
Oh, that's a good thing. They're busy.
Yeah.
Good. All right. Well, thank you so much for joining me again on the podcast. You're always welcome. And I hope that patients get a more understanding of where I think our medical system is moving and maybe why from this discussion today. And I think it's a very important discussion, though kind of a difficult one. So thank you for having that with me. Yeah. All right. Tune in next week, everybody. Thank you so much.